as a custom in the IMAP state.
Dr. Narasimhan has done his MBBS from Osmania Medical College and is a member of National Academy of Medical Sciences General Medicine, Delhi. Due to his passion for rural service, he has built a team of 150 doctors and 9 hospitals at Hyderabad for rendering his service to the Satya Sai Seva organization. He was invited by Bhagwan Sri Satya Sai Baba as director of Sri Satya Sai Mobile Hospital, Puttaparthi since its inception in March 2006. Through his exceptional commitment and innovative skills, he built a team of more than 300 doctors of all the specialties to render voluntary services to this mobile hospital. He has also won several accolades for his activity and for the model of rural health service like National Award by the CNBC channel and Cambridge School of Medicine UK for the year 2012. He also holds an additional responsibility of being the superintendent of the Sri Satya Sai General Hospital, Puttaparthi, for the last 2 years. Thank you, sir, for your presence over here. Now I request Dr. Narasimham Sir to give a lecture on Ideal Rural Outreach Health Service, a pragmatic approach.
This also I can change now, here itself. A very good afternoon to you all. I offer my humble salutations to the Almighty, my grateful thanks to the organizers, my greetings and pranams to all the assembled doctors today. I'll be making a presentation today on an apparently simple subject, on a subject relating to public health. And the title of the subject, as you can see, is Ideal Rural Outreach Health Services. In the midst of rich, varied discussions and deliberations going on in the academic context, this may look a surprise for you to have a presentation on a subject of public health. I hope it is a pleasant surprise, maybe a change from the routine also, in the midst of serious academic discussions. But I am sure at the end of the day, you will agree that this subject is not only important and vital, but perhaps crucial for our country. It is very crucial in our attempts to provide ideal health care to the people, to the community at large, which as doctors we know it is our primary goal and which we are also duty bound to provide. My talk today will have 3 components so that I am crisp, brief, and at the end it is etched in your minds as a good take-home message. Firstly, I will try to portray the sad and pathetic state of our country's rural health services. Secondly, I'll try to provide a solution in the form of a time-tested model of rural healthcare delivery, namely Sri Satya Sai Mobile Hospital at Puttaparthi, which is operational but very silently operational for the last, mind you, 17 years. The third component of my presentation will be a few humble suggestions to the government for replication at the governmental level. Dear friends, we all know that India is a land of villages. 70% of our population still lives in villages. Gramavasini Bharati, we call. But paradoxically and unfortunately, 80% of all medical services in villages, in 80% of all medical services, let it be infrastructure, medical facilities, diagnostics, presence of competent and qualified doctors, all these are concentrated in towns and cities. It's unfortunate, 70% of the population is in villages. The governmental healthcare delivery system also, mind you, is the same age-old three-tier pattern, pattern, with teaching hospitals and medical colleges being in towns and cities, district hospitals being in district headquarters, community health centers and primary health centers being in mandal headquarters. The villages, which represent 70% of the population, have nothing. They are at the mercy of quacks, not ordinary quacks, dangerous quacks, you know that very well. They are at the mercy of primary healthcare centers, which you all know are rudimentary centers. Is this not a gross injustice? 70% of the population being denied of healthcare? We may not perhaps think of it, but it is a stark reality. This has been, I would say, the unkindest cut of all ever since independence. And this injustice is being perpetrated by government after government. Not only that, the rural healthcare delivery system, as you can see, is caught in what I would say a tricky triangle. On the one hand, the government says it has a number of problems, challenges, and constraints, but the principal one being the inability of the government to transfer technology to the peripheral health centers because there is no mechanism to install, maintain, service these sophisticated equipments, especially diagnostic equipments. On the other hand, there is a common complaint that doctors are reluctant for rural service. Doctors have their own valid and justifiable reasons. On the one hand, the lack of infrastructure in the peripheral health centers. On the other hand, the lack of life amenities, like say good schools for children, makes both professional and personal lives of doctors unsatisfactory, and thereby rural health service becomes unattractive. The base of the triangle, the third limb of the triangle is constituted by the constraints which the villagers have to access even the existing services which are available in towns and cities. And as you can see, there are a number of reasons for that. Firstly, they are being engaged in daily wages labor. I know this very well because I have been a field worker in the periphery. For them, if they don't go to work for one day, it means compromising with that square meal for that day. Secondly, you know, there are senior citizens at homes for whom there's nobody to take them to hospitals in towns and cities because all the other members are away in the fields. And women have a dual role to play, work at home, work in the fields. And fourthly, there's a huge lack of awareness even this day, notwithstanding so much of mass communication, so much of communication tools, but still there's a huge lack of awareness, ignorance about so many aspects of health and disease. If you ask me, I can list 100 of them, but constraint of time, I would only limit myself to telling that even basic aspects of health and disease, in spite of so much of advancements in science and technology, villagers, 70% of our population still is not aware of it. It is in this difficult situation, this grim scenario, way back in the year 2006, my master, Bhagwan Sathya Sai Baba, struck what I would say the master stroke in the form of what is called the Sathya Sai Mobile Hospital, which in the next 5-10 minutes I'll be narrating to you. Having provided excellent models, exemplary models in the field of primary and secondary healthcare by starting well-equipped general hospitals which provide free medical and health care. In the way, starting from the year 1960, Bhagwan Sathya Sai Baba also started excellent exemplary models in the field of tertiary health care, high quality health care, world standard hospitals which provide free treatment in the form of the super specialty hospitals. But in the year 2006, he propounded the concept of what he called outreach care. He said, high quality care is not enough if you provide, you have to deliver it, he said. Provision means the service is rendered by a static hospital, while delivery means you yourself reach out because India is the land of villages. You need to reach out to these poor, unfortunate people. So the concept of outreach care was propounded by Sri Satya Sai Baba. Knowing fully well the genetically defective rural healthcare delivery system in India, he made a simple innovation. He said it is not necessary to build hospitals or buildings. It is not necessary to install technological equipments in the periphery. He said, fit these equipments into a mobile bus, and then these buses can be sent to the villages. The doctors, but he said, mind you, it should not be a window dressing exercise in the form of so-called episodic, sporadic medical camps. He said, competent and qualified doctors, Vaidya Nipudulu, he said, should accompany the diagnostic bus. A makeshift hospital can be created in a village, as we do, by using the structures available in the village, like say the village school or the Gram Panchayat building, and quality medical care can be delivered from morning to mid-afternoon, and by evening the diagnostic bus with its equipments can come back to the base point for any preventive maintenance work. Doctors also can come back to their homes in the evening. It will be like any other job for them. They go in the morning, they come back in the evening. They can have the best of both the worlds, both in their professional and in their personal lives. This apparently simple but innovative solution has revolutionized the concept of rural health care by converting it into what is called rural outreach holistic health care. We shall now see, having devised this ideology and also developed a methodology for it, what was our modus operandi? How did we go about? Because as you know, any successful methodology depends on a good ideology, but we need to have what's called an operational strategy. Basically, we did a twofold exercise. Firstly, a study of community health diseases to identify what is called the community disease spectrum and the community disease load, words which are used in public health parlance. Secondly, what are the components that are required to see that this outreach service becomes a quality service and not a window dressing exercise? So when we did the first exercise of study of community diseases, we quickly realized that ailments in any community, especially the rural community, fall broadly into 6 categories, and this applies to every organ system, to every specialty. This sort of a classification you will not find in any other public health book. It came out from our hearts. It came out of our experience in rural service. So as you can see, first are the common ailments. The word is self-explanatory. But if you ask economists, the loss of man-hours which takes place even because of common ailments, the loss to the community or the country is fairly significant. Second are the chronic ailments. You all know very well about this, the lifestyle diseases especially. These are ailments which are prolonged or even lifetime, where there is the requirement of a periodic or a regular medical examination, monitoring, investigations, and an uninterrupted use of medicines. And if you look at the dynamics of our population, if there is 25 to 30% of the population is affected by one or the other lifestyle disease, diabetes, hypertension, heart disease, strokes, it is mind-boggling. The numbers are simply mind-boggling, and mind you, the government doesn't have a strategy, doesn't have a mechanism, doesn't have a thinking of how to handle and tackle this big chunk of the chronic ailments. Thirdly, we have intricate ailments which are diagnostic challenges and which require a multi-specialty approach, higher modalities of diagnosis. What I mean to say is, even if it is an outreach service, you need to be equipped with all this, and that happens when you incorporate all these components. Fourthly, asymptomatic ailments where the individual will not have a problem but will have a disease. And it requires what is called screening programs to unearth the hidden disease. For example, we do cancer cervix screening by adopting the World Health Organization approved technique called the VIA method. It is done on the field. Cervical biopsy is also done. It is not just a screening, but the biopsy is taken back. We have our pathologist, Dr. Srikanth, sitting here, an eminent professor of pathology. And based on the reports, CIN 1, 2, 3, the treatment is accordingly planned. Next is preventable ailments, where if you have a robust health education exercise done, service rendered, the community disease load comes down. And finally, we have medical emergencies which cannot be handled by an outreach service. Some first aid can be given. And you know very well, even our primary health centers cannot handle these emergency situations. It requires advanced care, maybe district hospitals or tertiary hospitals in the city. So anyway, once we classified the ailments as belonging to these 6 categories, we now thought, what are all the components we should integrate into our kit of rural outreach service? What are all the arms we need to take in our armamentarium? Knowing the strength of the enemy, how are we going to go about? And then we identified 6 components which we fitted into the mobile hospital. I am using the word we, not in a very personalized way, but it will definitely throw up lessons in the process. First thing is, the rural outreach service, we realized, has to be a regular, serious, and a sustained exercise. It cannot be, as I said, a sporadic or an episodic medical camps conducted by so many other organizations. It has to become a part, an integral component of the rural healthcare delivery system, even if the government takes it up. So what we did was, we mapped the geographical area around Puttaparthi, and we identified 12 nodal or base villages in 6 mandals. The mobile hospital will go to each of these nodal villages on a fixed day of the month, whether it is a Sunday or a festival day, and deliver quality service, as I said, from morning to mid-afternoon. And this sort of a regularity and fixity in approach develops faith and confidence in the minds and hearts of the people. The next component we realized is, as I said, it cannot be an exercise where 1 or 2 MBBS doctors go and do some window dressing exercise. We recognized that it should be staffed by competent doctors. So on any particular day, we decided that 10 to 15 doctors representing all these specialties should be there on the field. Not only that, these doctors work under a common roof. They will be coordinating their efforts. They will be complementing and supplementing their efforts so that the best end-to-end solution comes at the end of the day. The third requirement which we realized is, having gone all the way, modern medicine, as you all know, is that of diagnostics. If the doctors are not equipped with diagnostics, the whole exercise becomes futile. So Baba said, on-site diagnostics, of course, these are some pictures of a service. Yes, this is about diagnostics. He said on-site diagnostics doctors should have, even if they are working in an outreach approach. So he gave us a beautiful bus which has an imaging section on one side, having digitized X-ray, ultrasound with color Doppler. We can do a 2D echocardiogram also, and a lab on the other. Not only that, the bus doesn't represent the mobile hospital. As I said, the village school, 5 rooms are taken and they are fashioned into department of medicine, surgery, obstetrics and gynecology, pediatrics, ophthalmology. For dentistry, we have a distinct bus with 2 chairs. So what I mean to say is that when there is on-site diagnostics, the quality of work automatically picks up. And at the end of the day, you can definitely come to an end-to-end solution for many problems. It is not that it's providing absolute diagnostics, but you will agree this sort of a lab and imaging facility will definitely enhance the quality of the service. The next requirement, we felt that we may be the best doctors, we may do the best tests, but at the end of the day, if we don't give medicines to the patient, it becomes a futile exercise, because these patients can't afford even a square meal. So we have a rich pharmacy, and I'm so glad to tell you that for all lifestyle diseases like diabetes, hypertension, all these diseases, we give them 1 month medicine. And this should be done by the government. The government is capable of doing. In the end, last 2-3 minutes, I'll throw up suggestions by which the government can do this. As you all know, 10% of ailments, by experience I can say, cannot be handled on the field. And we require a viable backup support. And this is required for where, example, you need to have a prolonged inpatient medical management, or where higher modalities of diagnostics like CT scan, MRI scan is required, or where surgical interventions are required. But the mobile hospital doesn't wash off its hand. It does the initial workup, the initial diagnosis, the initial surgical profile, and then these patients are brought to our base hospitals, the Satya Sai General Hospital and the Super Specialty Hospital, where the care is delivered. So a presence of a viable backup support, in the case with government, it can be the district hospitals or the teaching hospital, medical college. Government does have all the infrastructure required in what all I am listing. And then finally we realized that since we are going into the community, we are not staying aloof from the community, we are best placed to enter into the lives of the villagers and bring about changes for the better on aspects of prevention. So preventive service in the form of an ideal health education became an integral and important component of work of our outreach service. And we identified 6 main topics. As you all know, the 6th one is the most important now, COVID-2 as I call it, the lifestyle diseases. And then we do this health education at the individual level during doctor-patient interaction, at the family level, when we go in the evenings to the villages and branch off into 2 or 3 groups, sit informally with the villagers and discuss a wide variety of topics pertaining to health and disease. This can be done again at the group level, not only doctors, but even trained paramedics. And finally, the whole teaching can be reinforced at the community level. The village center point, we erect a stage and show them documentaries on many vital subjects. And not only that, there are formal talks, informal talks, interactive sessions and all. And the secret which we discovered in the process is, if we do an outreach service integrating both curative and preventive care, the receptivity for your teachings on health education is very wide. And people are prepared to listen to you. Whereas in the government, these 2 things are done in isolation, and that is why both of them are not productive, especially the preventive part. You will agree that in governmental setup, there is no preventive exercise which is worth its salt, which is worth its name, which is done. The spiritual dimension of health, as I would say, in fact, when I showed you this triangle, the base of this triangle is what I would call a spiritual base. And this doesn't pertain to any particular religion or cult. We all now recognize that mental health is crucial for physical health. So we tell the patients who are very receptive to us that they need to foster their mental health also by positive thinking and by adopting age-old practices like prayer and meditation. And we tell them prayer is not for appeasing gods, it is to foster our own mental health. Anyway, when we created this sort of a system, an outreach system, where we have competent doctors on the one side, we have on-site diagnostics, we have a good pharmacy, and most important, we have a follow-up mechanism. As doctors, you will all agree that follow-up is an important component in medical parlance. The follow-up is ensured by being regular in the service. Like for example, on 3rd of every month, we are in a nodal village. Why I call it nodal villages? The nodal village serves as a hub, the center point for about 25 to 30 villages. When we are always there on 3rd, patients invariably will come back. The compliance rate is very high. So you can do a good follow-up. So when these 4 or 5 components are assembled, what happened unexpectedly is an academic environment got generated. The mobile hospital became a fertile field, became a gold mine for clinical material, and this can be used verily as a training ground for undergraduates and postgraduates. In the mobile hospital service, which takes place every month, now we have so many postgraduate students. Yesterday I had been at Kim Samlapuram where I delivered a talk. In the month of February, 8 postgraduate students, MD students came from there, and they all vouchsafed that they saw more clinical material than they saw in their own hospitals. And they said, from now, sir, we will not wait for your invitation, we will ourselves come frequently. So the academic dimension of an outreach service is huge. And this has to be capitalized by the government when it takes over. Because rural health service, the government always cribs that doctors should do. How this can be done, I'll show in the next two slides, and then I think I would wind up the presentation. Anyway, these are some facts and figures. A mobile hospital which operates from the 1st to 12th of every month as our Satya Sai mobile hospital, taking 12 nodal villages, we are able to serve a population of 5 lakhs. And I'm telling it from the bottom of my heart. I have data to support this because the whole system, the whole work in an outreach service, can you believe, is computerized, and where every day we are at a different nodal point. Still we set up an intranet using Wi-Fi. So if you look at the statistics, a mobile hospital of this sort is able to take care of 5 lakh population, and these are the different investigations, the scans, the x-rays which are done by the mobile hospital. So I would now come, having depicted the pathetic state of our Indian villages, having provided a model, a workable, viable model, I would now come to the last stage of my presentation by trying to make a few humble suggestions how the government can replicate this. As I said, if you take the population which is served for a state which has a population of 5 crores, 70% is rural, say 3.5 crores, one mobile hospital can take care of, as I said, 5 lakh population. So our state needs 70 mobile hospitals. And the capital cost and the recurring expenditure, you can see the capital cost would only be 175 crores, recurring expenditure of about 140 crores, which is not at all a big amount for the government, now that we have the National Rural Health Mission also to support us. But the most important question, kindly pay your attention to this, which is always cited by the government, is the problem of manpower, human resources. They say, how can we get the doctors? And for this, we have an excellent suggestion which we have made, which has been readily taken up by the Karnataka government, in-house postgraduate, DM, MCH. I would not call them students. They are doctors. They are qualified doctors. They have completed MBBS. They can be drafted into the mobile hospitals in a rotatory roster by posting them for 3 months in their second and third year of study. And if you ask me, have you made a calculation whether these PGs in the state will be enough? Yes, I have made. The number of PGs who are there available second and third year are more than enough to run the 70 mobile hospitals. And expenditure will not be extra because PGs are already paid stipend. So under the salary head, you will not have any extra expenditure. And not only that, PGs are more dedicated, they are accountable, they want to learn their subject, and they are always, under the control of their professors. So obviously the quality of the service will be much better. Whereas for a service like 104, government is struggling with one doctor. Why not have this innovation? And thereby, you always say doctors should do rural service. How they can do when you post them to a primary health center where there is no basic infrastructure, where at the end of 1 year, they would only end up by forgetting their subject or by their surgical skills being less sharper than before. So this is an excellent suggestion both to run the rural outreach service and also to ensure rural health service for doctors. I would conclude, because shortage of time, I have to race up. I will conclude by showing one very interesting slide which really portrays an outreach service, what is its nature and how superior and noble it is. As you can see, the Satya Sai Mobile Hospital, for example, or for that matter any mobile hospital, is an example of an outreach medical service. Outreach care is now the 4th dimension of medical care. We have primary care, secondary care, tertiary care. Outreach care is the 4th dimension. But these 3 different cares are individual entities by themselves. They do not incorporate anything beyond their own limits. Like our own Satya Sai Super Specialty Hospital at Bangalore provides in the field of cardiology, cardiothoracic surgery, neurology, neurosurgery. But it doesn't provide primary or secondary care. Whereas outreach care is the most superior, most noble, because it goes into the community. It serves the people at or near their doorstep. Secondly, it delivers holistic health care, a fine blend of curative and preventive services. And finally, the most important, it includes all the 3 different levels of care, first, second, and third, primary, secondary, tertiary. The mobile hospital, for example, delivers primary and secondary care on the field. Tertiary health care, there is a system which ensures continuum of care and which sees that these patients who require tertiary health care are delivered at the base point. So this is a unique and noble service wherein all the 3 levels of care are subsumed, are taken in a loving embrace by the outreach service. And that is the service which a country like ours, wherein 70% of the population is still in the villages where they're denied even basic health care, and where now we cannot, it is genetically defective, the system, the 3-tier pattern which I showed, primary, secondary, and health care. We are left only with this beautiful innovation which was made by my master, and it is left to the government. I don't know whether the Vice Chancellor and all are still there, but I would fervently request, because the Karnataka government sent a team of IAS officers, their Chief Secretary Vandita Sharma is very much interested in this, and after they made a field visit, they decided, the Chief Minister himself announced in the Assembly that 5 mobile pilot project. Yes, definitely we need to have a pilot anywhere. 5 mobile hospitals are going to be launched in June. I think I have given you a bird's view of our country's rural pathetic health scenario. I have shown you perhaps a workable, viable model of rural health care in the form of Satya Sai Mobile Hospital. And finally, very humbly, I have put forth a few suggestions for its replication by the government, addressing the most difficult part in terms of human resources by suggesting that in-house postgraduate doctors and DM doctors, MCH doctors should be drafted into the scheme. By this way, I think I have made my presentation complete. Shortage of time, I couldn't really dilate upon many of the points. All the same, thank you all so much for your patient hearing. Sai Ram. Sir is one of the eminent professors of medicine who, it's a great privilege for us to have him regularly in the Satya Sai Mobile Hospital at Puttaparthi. I really wish that many more doctors who are here kindly come at least to make a study visit of this beautiful innovation which you should never miss being doctors. Thanks, sir.